All right, guys, I think we'll get started here. So I'm Ben Abrams. I think I've worked with all of you at least once. Worked with all you guys at least once. Today we will be talking about neuromuscular blocking agents. We'll give a brief introduction, some of the history behind these medications, physiology, normal physiology, mechanisms, a discussion of what really the indications are for neuromuscular blockade, some drug-drug interactions, as well as medical comorbidities, which are pretty high yield, both for the ITE and your written boards. Talk some unique features of some of the individual meds, briefly some monitoring discussion, although I think you get a separate lecture on that, reversal, and then a few questions scattered throughout there. So all of our non-depolarizers are based on a chemical called curare, which actually has been around for hundreds of years. It was originally refined from certain plants in equatorial rainforests and was used for hunting across 3 different continents all around the same time: South America, Africa, and Asia. And the 1500s actually had its earliest documented use for hunting. And interestingly, from a pharmacology standpoint, which we'll get into, even if you kill whatever animal you're using with curare and then eat that animal, you won't get paralyzed. So we will go into some of that pharmacology. Some of the first medical indications were in the mid-1800s with an application for people with tetanus. And then the first anesthetic application actually were in some Germans in the early 1900s tried to use it for intra-abdominal procedures, but intubation was not routine at that point, so that didn't work out very well. So the first real successful use was not until the 1940s. And then on the other side of the neuromuscular blocking agent, succinylcholine actually has been around for quite a while and has maintained status as the gold standard for RSI since the 1940s and 50s, although that's also changing now that we have Sugamidex. So I think as these questions get generated from a comorbidity standpoint and drug-drug interaction standpoint, if you can understand some of the basic physiology at the neuromuscular junction, you won't have to memorize all of the interactions, because a lot of the questions you'll get are, this patient has X comorbidity or is on Y medication. How is that going to affect dosing of Z neuromuscular blockade? So we will go through this very quickly and highlight some of the points so that we can then think through some of those questions as opposed to memorizing an entire chart. So very briefly, lower motor neuron activation occurs. There's a whole process for how that gets transmitted down the axon, but once it reaches the nerve terminal and the neuromuscular junction, the neuron depolarizes. You have an influx of calcium. Calcium stimulates synaptic vesicles, which are filled with acetylcholine, to bind at the motor endpoint, release acetylcholine into the neuromuscular junction, and that acetylcholine then binds receptors that we will go through here in a second. So the channels that we're working with in this portion, and then the receptors that we specifically bind, are important for how we can think through some of these questions. So again, acetylcholine is being released. It binds to nicotinic acetylcholine receptors, which is important to remember as we talk about, in particular, neostigmine and some of the muscarinic side effects, and also think through some of the side effects of our non-depolarizers. For the postsynaptic nicotinic acetylcholine receptors to actually open, 2 of the alpha subunits, both of the alpha subunits have to be bound by acetylcholine. And when that happens, the channel opens, you get depolarization of the muscle, and then all the calcium, actin, myosin, which is a separate lecture. That process goes on. and you get muscle contraction. So here, Curari is the example. You only have to have one of these alpha subunits actually bound by the neuromuscular blocking agent to prevent, since you need both of them to be bound by acetylcholine to prevent any opening. I know that's relatively simple and superficial explanation, but does that ring a bell from med school and make sense thus far? Okay. So indications for neuromuscular blockade actually are not so cut and dry, and there arguably are very few absolute indications to paralyze someone from an anesthetic standpoint. So immobility during surgery is certainly a goal of any general anesthetic, but it does not necessarily require neuromuscular blockade. I'm sure you guys have done big spine cases at this point with neuromonitoring where you can't paralyze someone. People tend to stay still 95% of the time with high-dose narcotics, and we get through things just fine. So you either have to block an afferent pathway or an efferent pathway, and whether you're going to essentially completely eliminate their pain with high-dose narcotics or paralyze them on the other end of the spectrum, that gets you immobility. There is some debate whether or not paralysis actually improves surgical conditions. So there's some studies with lower abdominal surgeries looking at vecuronium versus placebo that actually showed improvement in operating conditions, but these are all subjective scoring systems by surgeons, so somewhat debatable. And then from a safety standpoint, immobility during surgery could be argued in specific cases. For example, intracranial procedures where people are stuck in pins. If they cough or buck at all and dislodge those pins, that can be a catastrophic event. So paralyzing for that kind of indication is a reasonable argument, although, again, we can certainly make that happen with high-dose narcotics. With respect to intubating someone, with adults, 99% of the time we will give some sort of paralysis, but it is not an essential component to being able to intubate someone. As you'll see at children's, you hardly ever give neuromuscular blocking agents because of pediatric physiology that we can chat about in a second. But essentially, to intubate someone, you need to effectively block a gag reflex, and you need to keep them from laryngospasming. So you can either do that by paralyzing them, or you can do that by blocking the afferent end of that pathway. You'll see at children's, you just give healthy kids a big slug of propofol, a little gas, and the cords are wide open because they're not essentially getting them deep enough that they're not going to laryngospasm or cough and gag on you. But the same, and because of their physiology, they tolerate that. Adults will not tolerate big doses of propofol, so we can kind of smooth out intubations, elective intubations on adults by giving some paralysis. That being said, there are contraindications to actually paralyzing people, so at some point you guys will intubate someone with propofol and remifentanil, and you achieve the same thing. So you don't necessarily have to paralyze someone to intubate. You just have to block their gag reflex and keep them from laryngospasming. There are some studies that, older studies, that paralyzing adults for elective intubations in the OR actually decreases vocal cord injury, but this is a little bit dicey in terms of the results and the conclusions that they make, but some people argue that that is an argument for paralyzing all your elective intubations. And then a final subset of people where we talk about neuromuscular blockade as a potential indication is both in the OR but also in the ICU in terms of optimizing ventilator synchrony. So you can certainly ventilate and oxygenate people much better if you have complete control of their respiratory physiology. But long term, it's harder to get people off the vent in the ICU if they've been paralyzed for a few days because they end up with a lot of deconditioning of their respiratory muscles. So we hardly ever paralyze people in the ICU now for that indication. Any questions about that stuff? So from a big picture pharmacology standpoint, you have depolarizing neuromuscular blocking agents and non-depolarizers. The depolarizing agents that we have available in the US, and when people talk about depolarizers on your tests, it's always going to be succinylcholine. And then the non-depolarizers are divided by chemical structures into the steroidals and the benzyl isoquinolines. There are over 50 or 60 non-depolarizers that have been used and invented at some point, but we'll just talk about these three in each subclass because those are the ones that are tested, and really only three of them will be available to you guys in clinical practice. So we'll start with the depolarizers, which is succinylcholine. So succinylcholine is basically just two acetylcholine molecules that are bound together. As we went through, acetylcholine actually causes muscle contraction, so it's initially a little bit counterintuitive for how this type of medication could actually paralyze someone. And how this works is succinylcholine arrives at the neuromuscular junction. It binds to these nicotinic acetylcholine receptors, and initially it will stimulate muscle contraction, as you see with muscle fasciculations, but that eventually turns into paralysis. And this has to do with the specific sodium channels that we're looking at, and you may or may not remember this from med school, but there are time and voltage gate dependent aspects of these channels. So in the resting state, which is on the left side of the screen here, the time aspect or the time gate is open and the voltage gate is closed. After succinylcholine binds and causes that depolarization, because the voltage reaches that threshold, the voltage gate will open. The time gate is still open, but eventually the time gate closes and the voltage gate remains open. And this is the deactivated state. So succinylcholine essentially maintains the receptor and the channel in this state, so it's not available for further depolarizations or with other stimulation from acetylcholine. So that's a little counterintuitive, but that's the physiology behind how it works. And then there's some arguments. Well, it is somewhat debatable for how it maintains that deactivated state, but there seems to be some sort of acetylcholine receptor desensitization, and then some brief transient sodium channel deactivation. You'll hear all these terms, but that's the general pattern and mechanism for how succinylcholine actually paralyzes someone. From a pharmacokinetic standpoint, succinylcholine is rapidly degraded in the plasma by pseudocholinesterase. So only 5 to 10% of that IV bolus actually reaches the neuromuscular junction. And this is important in certain states where pseudocholinesterase levels actually are upregulated, including obesity. And this gets into important both clinically and from a test question standpoint in terms of how we should dose these medications. So succinylcholine should be dosed by actual body weight. And again, this is because as people add fat to themselves, they get an upregulation of pseudocholinesterase. So to continue to achieve at least 5 to 10% of the drug arriving at the neuromuscular junction, you need to adjust accordingly. As we'll see, the non-depolarizers should be dosed on ideal body weight. And then with this rapid degradation and dependence on pseudocholinesterase, people with different forms of pseudocholinesterase and deficiencies have variable durations of action, which is something that's quite high yield and gets tested quite frequently. So I think some people get confused with the semantics of where pseudocholinesterase variability comes into play. So atypical pseudocholinesterase and pseudocholinesterase deficiency end up both prolonging the duration of action of succinylcholine, but from a pathology standpoint, they are very different. So it's important to separate those out in your mind. So atypical pseudocholinesterase, you have a normal absolute amount of the enzyme, but abnormal activity. And this comes with a variety of different genotypes and phenotypes for pseudocholinesterase, and actually there have been at least 20 different mutations identified that will give people an effective atypical pseudocholinesterase. This gets tested a lot because it's just very easy to get confused. But to diagnose pseudocholinesterase deficiency, there is a test and a result that has to do with the dibucane number. Dibucane happens to be a local anesthetic, but this has nothing to do with local anesthetics. Dibucane just happens to significantly impair the activity of normal pseudocholinesterase. So where these numbers what they end up representing and how you diagnose atypical pseudocholinesterase is that a normal person with normal pseudocholinesterase has their pseudocholinesterase activity levels inhibited by 80% because normal pseudocholinesterase is significantly inhibited in the setting of dibucane. If you're a heterozygote with a mutant, a heterozygous mutant, or I guess you're heterozygous either way, your dibucane number is 40 to 60% because you have a relatively smaller amount of normal pseudocholinesterase, so you get less inhibition. And then if you're homozygous for any of these mutations, your dibucane number will be less than 20 because you don't have as much inhibition in the setting of dibucane. Does that make sense? So just kind of understanding where those semantics come from can help you remember why lower numbers actually mean that you're a mutant. From a clinical standpoint, normal pseudocholinesterase patients will have duration of action with sucks of 5 to 10 minutes. The heterozygous patients the duration will be about 20 to 30 minutes, which clinically isn't really that relevant. But if they are homozygous for these mutations, they can have significantly prolonged effects of succinylcholine 4 to 8 hours, sometimes even longer. I had a patient when I was an intern that had undiagnosed atypical pseudocholinesterase. He was homozygous, and he was intubated for 16 or 17 hours in the ICU before he was then extubatable. So that's somewhat variable, but at least 48 hours from a test standpoint. So that's atypical pseudocholinesterase. Any questions on those numbers? So the other states that will prolong succinylcholine duration is pseudocholinesterase deficiency. And there are a variety of medical comorbidities that will cause this. Pregnancy is a classic one. In this case, it's just a dilutional effect from the normal volume expansion that occurs during pregnancy. Liver failure, uremia, malnourishment, burn patients receiving plasmapheresis, oral contraceptives. All these people can have relative pseudocholinesterase deficiencies. Again, these are normal enzyme patients from a functional standpoint, but they just have a decrease in the absolute amount of pseudocholinesterase. So the clinical effects are a little less consistent than the atypical pseudocholinesterases, but they can potentially have quite significant prolongation of succinylcholine. All of these states, regardless, will have a normal dibucane number. So that's important from a test standpoint. And from a theoretical standpoint, so like that patient I had that ended up staying on the ventilator for about a half a day, you could, in theory, give someone a whole bunch of FFP or whole blood because they'll get pseudocholinesterase from the plasma enzymes. So that's a kind of esoteric thought, maybe a little too much for a boards type question, but in theory you could get someone extubatable by replacing some of their pseudocholinesterase with transfusion. So we'll take a quick pause and do a question. For whatever reason, cholinesterase inhibitors come up quite frequently on boards exams, both IT and your written boards. Clinically, not all these really don't come into play, but It's pretty high yield, and you'll get some form of question with one of these cholinesterase inhibitors. So all of the following cholinesterase inhibitors prolong the duration of action of succinylcholine, except. Has anyone come across this yet, or any of these?
The answer's up there because they've shown the next.
Oh boy! How can we fix that? Good call. How long were you going to wait to tell me that?
I thought it was kind of nice because I could do
There we go.
Those will go away. All right, let's try this again. Okay, so edrophonium. So we will go through all four of these, and I will pick out some of the unique features that seem to get tested. So neostigmine is our standard reversal other than sugammadex, so that one we'll talk about when we talk about reversal. Physostigmine comes up when you get asked about treatment of anticholinergic overdose, so the 70-year-old lady that gets a scope patch and then is confused afterward. And the reason physostigmine actually is appropriate for the treatment of anticholinergic overdoses is that it unlike the other cholinesterase inhibitors, does not have a quaternary structure, so it crosses the blood-brain barrier. So that's how it can be used in the treatment. Edrophonium is used to diagnose myasthenia gravis and is unique that it does not impair pseudocholinesterase. From a clinical standpoint, for someone to get edrophonium in a neurology clinic to diagnose myasthenia gravis and then suddenly need a succinylcholine intubation obviously is pretty far-fetched, but that shows up on the boards. And then the last one, pyridostigmine, is used for chronic myasthenia gravis treatment. And
Your meeting has ended.
If someone is on pyridostigmine and their daily dose is greater than 750 milligrams, that threshold is one of the risk factors for postoperative respiratory complications. So that 750 milligrams per day is something to remember. So SUX certainly has a lot of side effects. Theoretically, so from a cardiovascular standpoint, PETS patients can Brady down with SUX, so you'll always have atropine or glyco available if you're going to give SUX to a pediatric patient. The reasons for that have to do with the development of the autonomic nervous system and how SUX works in some of the autonomic ganglia. And pediatric patients have a more profound hemodynamic compromise if they Brady because their heart rates or their cardiac outputs are heart rate dependent. Adults can get either tachycardic or bradycardic. It doesn't clinically seem to be a big issue for adults, and this really just depends because SUX is going to bind in those autonomic ganglia. It really depends where their baseline parasympathetic and sympathetic activity are in terms of how succinylcholine alters that. Succinylcholine counterintuitively does increase intragastric pressure, but it's an excellent medication still for rapid sequence induction, and that's because it also stimulates the lower esophageal sphincter. So while the fasciculations of your basically abdominal wall muscles will cause an increase in intragastric pressure, which increases theoretically the risk of aspiration, that as long as someone has a competent lower esophageal sphincter, so they haven't had gastric bypass or Nissens, anything like that, the aspiration risk gets neutralized. On tests, SUX certainly increases intraocular pressure. This has never actually been proven, but you want to avoid SUX and ruptured globes on the tests. If someone aspirates, that's far worse than leaking a little bit of eye fluid out in real life. And then intracranial pressure, this is also something that happens on the boards. SUX will increase intracranial pressure. It's possibly from, again, the fasciculations of the intra-abdominal or of your abdominal wall muscles kind of increasing preload. But we use sucks all the time in trauma situations, even when people have elevated ICPs. From a musculoskeletal standpoint, a lot of people get fasciculations, and those can lead to myalgias, which is an important side effect, especially you do quick outpatient procedures. Everything goes great from an anesthetic standpoint. Maybe they have a nice block, but some people will feel like they got hit by a bus. They're just sore for days, and it's from these profound myalgias. So you can essentially ruin a nice anesthetic by having someone feel like garbage for days from these myalgias. We'll talk a little bit about defasciculating doses and potentially giving lidocaine to prevent that. And then the last kind of feared complication is significant masseter spasm, where you induce someone, you can't actually open their jaw because they're so clamped down. And this is seen in patients with myotonic dystrophy, so you don't want to give sucks to anyone with myotonic dystrophy. Sucks is a known triggering agent. It gets asked not infrequently what comorbidities would increase someone's MH risk if they get sucks. And the only two proven ones are central core disease and King-Denborough. I will not begin to try to pretend to explain what those disease states are. They're obviously some sort of muscle issue, but those are two diseases to certainly memorize. And then the last sucks complication is hyperkalemia, which we'll chat about here in a little bit. So everyone that we give succinylcholine to will have an increase in their serum potassium. We estimate that for normal people that increases by only about a half. So as long as someone's starting potassium is less than 5 or 5.5, you're not going to cause a hyperkalemic arrest. The other important consideration with that is that succinylcholine actually is not contraindicated in renal failure. It's contraindicated if someone has renal failure and hyperkalemia. But this will happen to a couple of you. You'll be going to intubate someone in the ICU. You'll ask for succinylcholine. The nurses will say they have renal failure, and they'll try to argue that it's contraindicated. But if they've just been dialyzed, or you know their potassium is 4.5, sucks is not necessarily contraindicated, and it's certainly a useful drug in those situations. Traumatized muscle also increases patients' risk of developing hyperkalemia. So crush injuries, burn injuries, typically after about 24 hours. And that's because these types of injuries will cause an upregulation of some extrajunctional receptors. And these can actually last 6 months up to 2 years after initial injury. So if someone's had a massive burn a year ago and they're over an AOP for whatever reason, you need to really tease out the timing of when their burn was, and anytime you hear about a burn patient, you want to try to know if they're out of this range, whether or not they can get. Hello, succinylcholine. So with that, succinylcholine is just acetylcholine. So why do burn patients, when they get up and walk around, not have hyperkalemic arrests? So we have all these extra receptors, and if we stimulate them by giving acetylcholine at the neuromuscular junction, why do they not die? So succinylcholine is administered, and you develop levels systemically, so it reaches all these extrajunctional receptors. So the key to those semantics is that they are extrajunctional, so when you release acetylcholine at the neuromuscular junction, when you're going to fire a muscle, normal acetylcholine never gets exposed to those extra receptors. So you don't have to have burn patients stay still for 2 years, is the point. We talked about myotonic dystrophy, so those patients not only can have masseter spasm, but also hyperkalemic arrests. They seem to have more fragile, friable muscle fibers, as well as some upregulation of these extrajunctional receptors. And then typical muscular dystrophies, such as Duchenne's and Becker's, also are associated with with hyperkalemic arrests. And this is where the black box warning for succinylcholine in pediatrics actually comes from. These are both X-linked disorders, so they're more common in males. And the black box warning, I think, says in pediatric populations up to 12 or 14 years, and that's because these muscular dystrophies often are not diagnosed until that time. So you avoid sucks in basically in all pediatrics with a few emergent situations, as you'll see. Any questions about the hyperkalemic stuff? All right. I think the last point to make with sucks and ICU intubations. So if someone has been in the MICU for 3 weeks laying in bed, it's tough to tell when they should not get succinylcholine, but especially now that we have Sugamidex, ROC is a better way to go for most patients when you get called to the ICU and you don't know the whole patient's story. But someone that's been laying in bed for 3 weeks in the MICU probably has some upregulation, again, because they get a denervated atrophy of their muscles. Okay, so now we'll switch gears to the non-depolarizers. So these medications, unlike succinylcholine, which was actually an agonist at the neuromuscular junction, these are competitive antagonists of acetylcholine. Again, acetylcholine has to bind 2 of the alpha subunits of those nicotinic receptors for the channels to actually open. So if we block just one of them, we can't get to 2, and so we get efficacy, clinical efficacy, by delivering enough drug just to block one of those 2 receptors. The non-depolarizers are broken up by their chemical structures into steroidals and the benzyl isoquinolines. Rocuronium actually is the least potent of these medications, and that's actually why it's best for rapid sequence intubations. And this has to do with the law of mass action. So essentially, if you give a relatively high amount of the drug or of the molecules, since it's not very potent, you're not going to see a lot of side effects, but you're going to get a lot of drug to the neuromuscular junction more quickly than with other drugs that have relatively lower dosing levels. ROC is primarily cleared through the biliary tree. It actually undergoes very minimal metabolism, and there is very little renal excretion. So ROC is not contraindicated necessarily in renal failure. Certainly there are attendings that don't like to use it, but in renal failure. But if you are very careful with how you dose it and monitoring twitches, you can use ROC in renal failure just fine. We'll get into how to reverse those people later on, but it is, again, primarily a biliary clearance in terms of how to clear rocuronium. Vecuronium, unique features. It's been shown that with prolonged administration in the ICU, so when we used to use drips of vecuronium, there was an active metabolite that would accumulate. So these people had very prolonged duration of action of vecuronium. That is not used in the ICU anymore. And then pancuronium we don't have available, at least here anymore, but it still gets asked a lot because panc has unique hemodynamic features. Specifically, it has profound vagolytic and sympathomimetic effects, so you can get some hypertension, some tachycardia, and this is the long-acting non-depolarizer if you're ever looking for a long-acting one on a test answer. The other side of the group is the benzyl isoquinolines. So atracurium is degraded both by Hofmann elimination and plasma esterases. These are not pseudocholinesterase. These are of the same family as ramifentanil and esmolol in terms of enzymes that clear atracurium. Actually, can anyone tell me what Hofmann elimination actually means?
It falls apart on its own.
Yep, so spontaneous degradation at physiologic pH and temperature. So if someone's pH or temperature are way out of whack, that process will get significantly slowed down. But that's essentially what Hofmann elimination is. You do get a lot of histamine release with atracurium. And then one of the metabolites, lidanosine, has been shown to lower the seizure threshold. That shows up on tests. In reality, that has only been shown with really high doses of atracurium in dogs, as far as I'm aware. So you won't really use atracurium, but the seizure thing is probably a little overblown on tests as far as actual clinical data goes. Cis-atracurium is actually one of the more potent isomers of atracurium that gets isolated. It undergoes Hoffman elimination, but no plasma esterase elimination. It is unique from atracurium in that at clinically relevant doses, it does not cause histamine release. There is minimal to no lidanosine accumulation and this theoretical seizure risk. And because of all this, it's very forgiving and is now the drug of choice for prolonged paralysis in the ICU. Mivacurium is unique in this set in that it actually undergoes pseudocholinesterase metabolism, so all of that pseudocholinesterase deficiency and atypical pseudocholinesterase discussion also applies to mivacurium. It does cause histamine release, and it is short-acting. So in general, these medications are going to be your classic hydrophilic medications when you're looking for hydrophilic medications on a test. So if there's some question that's referring to an increase of volume of distribution, for example, a cirrhotic or a decompensated heart failure patient, and you're looking for that hydrophilic medication and there's a non-depolarizer on there, that's going to be the answer. So an example of how this gets asked is how cirrhosis will affect vecuronium dosing. So because your volume of distribution is larger with all of this extracellular fluid, you need a larger intubating dose. But because vecuronium is cleared through the liver, you'll need smaller maintenance doses. So those are kind of the little things that will get asked. Similarly, in general, as people age, they tend to have a relative increase in fat stores and decrease in muscle mass, which means they have overall less extracellular fluid, and so you'll get a decreased volume of distribution. So in theory, you can decrease your at least initial bolus doses of these medications. The onset time for these medications are very dependent on cardiac output, distance from the heart, and relative blood flow. So you get more rapid blockade at central well-perfused muscles like the diaphragm, whereas peripheral locations such as the adductor pollicis will take a little bit longer. So if you're actually looking at a twitch monitor when you go to intubate someone and the adductor pollicis twitches have begun to decline, the diaphragm has already been knocked out because the adductor pollicis takes longer to actually be affected. From a semantic standpoint, so the ED95, when we look at these medications, by definition actually is the median dose required to achieve 95% reduction in twitch height compared to the baseline in 50% of patients. So typically when we think about ED95s, it's how much drug is required to get the desired effect in 95% of people, but these semantics and how that gets calculated is a little bit different for non-depolarizers. Drug interactions get discussed and asked about all the time. This unfortunately is something just to memorize. For the sake of time, I won't go through all these, but this last bottom right section just gets into, again, this cardiac output dependent effect on onset time. So if you give someone ephedrine and their cardiac output increases, you're going to speed up the onset. If you give someone esmolol and you decrease their cardiac output, again, it's going to take a little longer for these drugs to reach the neuromuscular junction. So we'll talk a little bit about rapid sequence induction dosing, and I think this is very important clinically, but also from a testing standpoint for how we should be dosing these medications in obesity. So you have a 28-year-old female who's morbidly obese coming for her lap chole. She's 4'10", she weighs 100 kilos. with an ideal body weight of only 45 kilos. So if you're going to rapid sequence her with induction meds of propofol, fentanyl, and lidocaine, which of these options is actually the appropriate dose for a rapid sequence? And that's still hidden up there. Yeah. Okay. Anyone? So the SUX 120 milligrams IV is the correct dose. And this is very important. Again, SUX you need to dose based on actual body weight because obese patients get an upregulation in pseudocholinesterase, and you still need to get that 5 to 10% of the drug to the neuromuscular junction, whereas ROC and all our non-depolarizers are very hydrophilic, so they don't really distribute into all that excess fat, and so those should be dosed on ideal body weight. I think this is very important as we start to use ROC more for rapid sequence intubations because, for example, her RSI dose of ROC is 50 to 55 milligrams. If you give her 100 or 120 milligrams of ROC and you don't get the airway, how much C-Gamadex are you going to give? Because you basically doubled how much ROC you were supposed to give her. So if that patient doesn't do well and you're in court, I'm not a lawyer, but I could fry you pretty quickly by saying you don't even know how much rocuronium to give, and you're an anesthesiologist. So that's important to consider. Also, that's why SUX comes in a 200 milligram vial and ROC comes in 50 milligram vials, because you're going to end up using a lot more SUX. IM dosing of SUX for an RSI is 4 to 5 mg per kg of, again, actual body weight. And then, again, these other options are just mixing and matching ideal body weight, actual body weight with the correct intubating dose versus RSI doses. Does that make sense? So this is another slide where I'm not going to go through all of the different options of these medical comorbidities that get discussed, but we'll just go through 2 examples of comorbidities that get asked. And the question is how do they impact our dosing of these medications? So can anyone tell me what myasthenia gravis is from a pathology standpoint? Exactly. So you have antibodies that take out your postsynaptic acetylcholine receptors. So you're going to have less receptors at the neuromuscular junction. So for succinylcholine to work, it needs to bind and activate those receptors. So if there are less receptors for it to bind, you're going to have a relative resistance. Although, as we talked about, depending on what therapy they're on, if they're on a cholinesterase inhibitor, you may have some increased duration of action. But since the non-depolarizers are competitive antagonists, if there are less receptors that it has to block from acetylcholine, they're going to be more sensitive. How about Eaton-Lambert? What happens with that?
Antibodies to presynaptic calcium channel.
Yep, exactly. So if you have less of those calcium channels, you end up with less release of acetylcholine into the neuromuscular junction, so you get an upregulation. An upregulation of those postsynaptic acetylcholine receptors over time, so they're going to be more sensitive to SUX. Despite that upregulation, since there is less acetylcholine being released, they're going to be, again, more sensitive to the non-depolarizers through that competitive antagonism. Another thing that gets a little confusing is sometimes on the boards, Eaton-Lambert syndrome will be called myasthenic syndrome. So you get confused with myasthenia gravis. See, some of you guys have, I missed that question for sure because I just thought it was myasthenia gravis, but you'll get obviously opposite answers if they're asking about succinylcholine. I think for the sake of time, we'll skip over monitoring for now because you'll get a separate lecture on that. Something that comes up a lot and is tested a lot is anaphylaxis with neuromuscular blocking drugs. So a lot of people would guess at first glance that the most common cause of perioperative anaphylaxis is probably antibiotics. but it happens to be our neuromuscular blocking agents. Both classes have been implicated, and actually between the two, about 50 to 70% of perioperative anaphylaxis is probably due to neuromuscular blocking agents. The reason for this is that there's significant potential sensitization to common household items like toothpaste, detergents, cough syrups, and obviously for anaphylaxis you have to have an exposure to develop antibodies, and this is why it happens. As an example, fulsadine, which is in a cough syrup that used to be available in Norway, was taken off the market at some point in the early 2000s, and their incidence of perioperative anaphylaxis went from 1 in 5,000 to like 1 in 100,000, something quite profound like that. So anaphylaxis, think neuromuscular blocking agents. And there also seems to be some cross-reactivity between both classes. So if someone anaphylaxis to succinylcholine, it's not necessarily safe to give them a non-depolarizer, and those patients should go to the pre-op clinic and get allergy tested if they're having an elective case. Again, some semantics that I think get a little confusing when it comes to non-depolarizers. So there are defasciculating doses of non-depolarizers, and there are priming doses of non-depolarizers. The defasciculating doses are given when you're also going to give succinylcholine to try to prevent fasciculations with the goal of preventing postoperative myalgias. The data for that is somewhat debatable, but some people do it. You do need to increase your succinylcholine dosing slightly, and typically the doses will be about 10% of the ED95. So for ROC, that's 0.03 to 0.04 mg per kg of ideal body weight or actual body weight? Ideal body weight, perfect. A priming dose, which is also known as pre-curarization, is given to speed the onset of non-depolarizing agents. So if you give, again, about this 10% of the ED95 or 10% of your intubating dose, you can accelerate the onset of your neuromuscular blockade. And there actually is some reasonable data for this. So one study basically gave a standard cocktail of induction meds, but in one group they gave 10% of their intubating dose of 0.06 mg per kg. A couple minutes later gave 0.54 mg per kg, and the other group just got 0.6 mg per kg of ROC as the other meds were going in. And the onset time, as they measured by accelerometry, actually increased or decreased by 30 seconds in the priming dose group. So this seems to be a thing and might be reasonable to do. You're giving someone paralytic before they're completely asleep, so you have to be a little gentle with that. I've actually started doing this with our dilute ROC here, and no one's been paralyzed yet, but it seems to, I guess I'm a little impatient, and it seems to be helping at least until we get better ROC. We will talk briefly about reversal. I'm not that old, but neostigmine was all we had for most of my residency until the last couple months. It was much more difficult to use than Sugamidex. It gets asked all the time. So basically, your non-depolarizers are going to work through competitive antagonism. So to get rid of them, we're also going to reverse that competition by increasing acetylcholine at the neuromuscular junction. So we are reversing the nicotinic effects. Again, those are nicotinic receptors, acetylcholine receptors at the neuromuscular junction. We are not going to have competitive antagonism from our non-depolarizers at muscarinic receptor sites. So essentially, we're giving people organophosphate or sarin gas poisoning when we give neostigmine. So they can brady, they can bronchospasm. This is actually an important point. So you can't treat bronchospasm with non-depolarizing agents. People will try to trick you into saying that. But to prevent bronchospasm, when you give neostigmine, you need to give an anticholinergic medication along with it. It increases GI motility, secretions, nausea, vomiting. It does not cross the blood-brain barrier, so you don't get CNS effects. It does cross the placenta, so in theory you should pair it with atropine instead of glyco. And then if you overdo it with neostigmine, you actually get cholinergic crisis, and you can potentially make someone weaker, which can be a little bit difficult to tease out if you haven't given enough or too much. And then Sugammadex obviously is a very new drug, so in terms of what and when is going to get asked on the boards, I think is still a little bit debatable. We'll see. I'm sure more and more questions will come as the years go on, but it just got FDA approval in 2015. It's been available in the EU since 2008. A lot of the delay was concerned for anaphylaxis, which didn't really turn out to be a big issue. This medication chelates steroidal non-depolarizers. So you generate this one-to-one complex. You no longer have ROCK available at the neuromuscular junction. That complex eventually is cleared through the urine. And so there is some question about what to do with patients with renal failure. So like we said, rocuronium is fine to use in renal failure as long as you're careful with it. But some people argue that if the creatinine clearance is less than 30, you should probably use neostigmine. And then another debate is whether or not someone's on dialysis versus CVVH. So at least the circuits that we use at this hospital, the standard filters on dialysis units will clear the complex. But if someone's on CVVH, the ROC Sugammadex complex with the standard setup will not get cleared. So you can either call the nephrologist to have the other filter put on, or if they're on CVVH, just don't use Sugammadex. Again, these hypersensitivity concerns kept it off the market for a little while. Ironically, or not ironically, some people argue that if you have rocuronium-induced anaphylaxis, that giving Sugammadex might actually be part of your treatment, although true anaphylaxis isn't a dose-dependent process, so that argument is a little silly in my mind, but probably doesn't hurt anything. There is clear data that hormonal oral contraceptives actually will be impaired for up to 7 days when you give someone Sugammadex, so if you're counseling young females and pre-opping them, you should appropriately counsel them on how they're going to maintain their contraception for the week after their surgery. And then in theory, there's some QT prolongation. We'll roll through this very quickly. So we talked about obesity and pharmacokinetics. In theory, Sugammadex is hydrophilic just like the non-depolarizers, so you can probably use ideal body weight. A lot of people argue for actual body weight because you might get faster recovery. Obese patients are at higher risk for postoperative complications, so maybe you want to suck up all of that rocuronium. But I think when we get a little bit lazy with Sugammadex dosing, in that some people will just give, they only need 1 per, I'll just give the whole vial. The thing to keep in the back of your mind is if you have to reintubate these people in the PACU, they're going to either require an incredible amount of rocuronium, or rocuronium won't work if you've overdosed them on Sugammadex. So it's kind of pick your poison, and that stuff has yet to be clearly studied. We are now much more aggressive over the last few years about actually reversing people, and the reason for this is that people used to look clinically very strong, big tidal volumes, they could lift their head, but what was found about 10, 15 years ago is that there was a lot of microaspiration in the PACU because people had weak pharyngeal muscles. So that is actually the main indication for when people are debating whether to reverse someone. Even if they look really strong clinically, you're essentially preventing these little microaspirations that seem to be happening quite frequently in the PACU. All right, we got started a little late, but I guess we're just in under the hour there. Any questions about that stuff?
If you're going to re-intubate someone after Sugammadex, how much rock do you have to do? Just give them a ton anyway, right?
I have done it twice. There's one study that looked at, there seems to be some, it's like 2.5 or 3 hour threshold where you can probably give the normal amount of rock, whether you're going to give an intubating dose or RSI dose. It's only like 20 or 30 patients, and it's certainly something that's tough to study. So when I've done it, so what it depends on is how much rock they had on board, how much Sugammadex they got, and then how long afterward. So there is not a clear answer for how much to give. If someone was an easy airway to begin with, and you're not debating giving then another dose of Sugammadex because you don't think you're going to get the airway, the 2 times I've done it, I have certainly overdosed them on rock, and it's gone just fine. But I knew what the airway looked like. They're not getting extubated anytime soon if someone's going to get reintubated in the PACU.
Even like 2 per?
I ended up just giving an RSI dose based on actual body weight. They were both huge people. So there's no science to that, but it worked. But if there's no contraindication, you can also just give sucks. Have you reintubated many people after Sugammadex?
After Sugammadex?
Yeah. Yeah, I've only had to do it twice, and it's gone just fine. But there's a lot of pharmacology that goes into whether or not it's going to work. And if they're that sick that they're getting reintubated, maybe you don't need anything. Any other questions? All right. Thank you, guys.
Does anybody see Nick?
Yeah, he's outside having a powwow. A bunch of powwows.
So did you know if there's a way that only I can see the notes and they don't show up there?
Well, so you were probably, were you using the online one?
I downloaded it.
It's not supposed to show it.
Okay. So last time I didn't have.
No.
I was like, oh, I got it. I noticed it.
I'm not quite sure what happened.
So it's not supposed to. Hopefully I didn't forget anything with that one.
There's nothing scary.
Okay. All right.
Dr. Oliva, could you sign back in so we can sign in?
Did it sign out?
My badging, don't know your own meat.
Try now.
Yeah, that does show the each time. Let's try that first.
I mean, I bet you solved it.
So we have to make DC.
Thanks for talking. Thank you. Yeah. Excited for it. So, yeah, it's cool. Like,
Yeah, did you see what GOGG? No, that was probably him.
Oh, and then now, so now what?
It looks like it's up there. And then it goes away.
of course.
Let's see. Yeah, we're thinking about it. Like how you like bypassing.
No. I asked you. And you said, let me ask Kate. 48 hours later, and you hadn't asked Kate. And then I also realized, wait a minute. Because you would be here. This weekend. So like, actually, it won't matter if
Yeah, I need to be here. Yeah.
go and walk through
He's like, all the patients have feet, so no.
Sorry. Now that you said it.
Just go ahead and read to yourself. Okay, now just pull it up. See if you can So when I had my Mac, it was giving me that same stuff where it'd be on and turn off. I don't know if it's a power thing or if it's just some Mac specific. Since I've had a PC, I haven't done that to me. Huh.
So everybody, while Nick is getting this set up, what did you guys think of the vet resident last week?
It was awesome. It was the best ever.
Was that cool?
Yes.
So like I said, I'm going to be going up there with Angie Seltzer next month to kind of see what they have for facilities and see what we can do. I think my hope is that every single person will be able to get that opportunity for at least a week. But depending on the way they have staffing up there, we might not be able to do that. So I'll update you as soon as I have more information.
Can we come back after we graduate?
If you can do it, though.
That'd be cool. Can I make a special request?
We'll let you know when they go to the zoo.
We're just gonna go into the we're gonna find a garden. You're gonna
And then a couple of other things I wanted to touch base on real fast. I think you all got an email from the chiefs. We're starting to work on the schedule for next year. So the CA1s, make sure you respond about things that you want on the early part of your year. For the CA2s, make sure that you look out for a survey that I'm going to send out. That survey is going to be looking at both clinical rotations and your preferences for those rotations, as well as a open text box for you to say if there's something else outside of the clinical core rotations that you'd like to have done. So research or some other activity that you want to pursue. And that's about it for scheduling and stuff. I hope to have a pretty rough draft of that schedule by the end of this month. So we'll start looking it over. I'll probably meet with you individually just to see, like, hey, this is what your schedule's looking like. What are your thoughts? Get some feedback before we make it go live. Cool. Any questions about that? All right. So Nick wanted to give this talk. This was initially the big snowstorm we had in October. We were going to be doing a clinical case conference, and one of the things that Nick wanted to talk about was some of his experience with QI, because he felt like he had some things to be able to share with you. So this is his talk.
Cool, thanks. Yeah, so I did a decent amount of like QI work while in med school and everything, and you know. Yes, that's correct. It's actually it was in public health school, which was also at Harvard. So, yeah, I have 2 degrees out of there. So, you know, I feel like the program here is trying to really ramp up a lot of the QI stuff, and so you know, I felt like it'd be useful to go over some of the tools that I thought were really helpful for doing a QI project. So that's what we'll be going over today. So our objectives. So the first one, you know, I know a lot of us have heard of like root cause analysis and performing that stuff, but I was going to go over kind of one of the ways that you can do it and kind of a step-by-step way that you can go through performing a root cause analysis, some of the terminology with it that I think we don't necessarily get introduced to so much. So we'll talk about the different components. We'll talk about the 5 whys concept, which some of you may have heard of. but why we do the 5 whys and how we kind of validate the 5 whys concept. We'll go through a fishbone diagram, which I assume most of you have also seen, but what the different categories can be, how you set one up, how you actually use it like effectively. And then we'll kind of do an example together to show how to step through one of those in a more systematic fashion. We'll talk about Pareto charts. I don't know if anyone here has heard of Pareto charts. Maybe if you've done an MBA, you've probably heard of Pareto charts. We'll talk about that, their utility, kind of how those follow a root cause analysis, and how they can make your root cause analysis more effective. We'll talk about the Pareto principle, which underlies Pareto charts. And then we'll talk about control charts, which comes a little bit after you do a root cause analysis and all that, but I think it's a really helpful way to show your outcome variables, how your processes are trending, what you can kind of glean from that, and then when to use each of these tools in the QI process. All right, so starting with the root cause analysis. So when do we do a root cause analysis? Anytime I do a QI project, I think of it in terms of 8 steps. And your root cause analysis really comes about halfway through when you start identifying the causes to your problem at hand. So the first things you'll be doing will be figuring out your problem statement. Then you'll be identifying who your stakeholders and your customer are. You'll be deciding on who your team is. Doing a really good job of understanding what your current state. And then at the next step after you've done all that and really have a good foundation for moving forward with your project, that's when you want to start identifying your causes. And the first thing you'll really be doing there is doing a root cause analysis. So step 5 of my 8-step process. So again, what is a root cause analysis? It's a methodology to identify what the root cause or causes are of the QI problem at hand. And I think it's important, to think about that there's not necessarily just one underlying root cause to your problem. A lot of times, especially in healthcare, very complex environments, that there can be multiple root causes contributing to your problem. And so it's good to, have that breadth in mind when you're going through a root cause analysis. And this should always be included or completed with the inclusion of your stakeholders and then your content experts who are going to be part of your team. So the components to root cause analysis, you're really going to have 4 components. The first one will be identifying your problem, which you, in the 8-step process, you've already done that by the time you've gotten to the root cause analysis. But then what you really want to do is you want to differentiate the types of causes that can go into the analysis and the things that you'll be identifying while you're doing the analysis. You'll want to establish a timeline. So chronicity is really important when you're thinking about how your causes link together to get to your root cause of your problem or your root causes of your problem. And then really the big thing with QI, a lot of times all of us are very scientifically minded. A lot of us have science backgrounds, but a lot of times when you're presenting QI work, it's to non-science people. So giving them these really complex diagrams and graphs and p-values and yada yada is really not helpful. It's not convincing. And so trying to represent your results and the work that you did through this in a simplistic way that's predictable is really helpful. And so that's really where the fishbone diagram comes in, where a lot of people who have an MBA have seen that a lot. So starting with the types of causes. So the first one, root cause, which is pretty obvious, but I think the best way to think about what actually is a root cause for your problem. It's something that if you were to remove that cause from the process, that the problem would then go away and it would not come back. So that's something that's really important to keep in mind, especially when you think about another type of cause, which is a causal factor. So causal factors are upstream of your root cause. They're in between your problem and your root cause. And removing them sometimes will alleviate the problem for a little bit, but eventually your problem will come back because your root cause is still present and you haven't really dealt with it. So kind of the way I like to think of this is, if your problem is, my car doesn't start, right? And then you might identify it's because, the battery's dead. And so I'm going to go change the battery. But the battery's not your root cause problem. Maybe your root cause is that your alternator's actually not good and that needs changed. So the battery being dead would be a causal factor. The alternator's your root cause. And then maybe there's even a root cause beyond that if you kept drilling down. But I think that's kind of a good way to think of that. And then the last one's non-causal factors. which is pretty obvious. If you remove these, you're not really going to affect the problem at all. And so again, with the car analogy, if you said, well, the last time this happened, it was because I had a bad spark plug, so just change all the spark plugs out. Obviously, that's not going to do anything if it's, your alternator's bad. This one, I think it's important to think about non-causal factors while you're doing your root cause analysis. This is where a lot of people get tripped up. I think this tends to be the low-hanging fruit when people think about processes, what's going wrong in the process. They'll say, oh, well, it's just X that's going wrong, so let's just fix it and let's just move on. And a lot of people spend a lot of time, a lot of resources actually dealing with non-causal factors. So really thinking about when you're coming up with your causes for what your problem is this actually causal or not? Because you're going to waste a lot of time if it ends up being a non-causal factor. So these are kind of the three terminologies, I guess, in terms of root cause analysis to think about. Then the next component before sitting down and really constructing like your fishbone diagram is thinking about the timeline and the chronicity of your causes. So one, if you have multiple causal factors that are in between your problem and your root cause, they should occur one after the other. And so you should really think about how they link up, and it should be a logical and chronicle flow from the problem through the causal factors to your root cause and then back the other way. And so one really good way to think about this is using the 5 whys concept. And so the 5 whys concept is pretty simple. It's just that you should, anytime you come up with a cause for your problem, you should ask, why is that cause in effect right now? And then you come up with a deeper cause for that cause. And usually, this is a little bit soft in terms of, there's no mathematical proof for 5 versus 6 versus 7 whys. But, usually if you drill down and ask yourself why 5 different times, that most of the time you will end up at a root cause after 5 whys. So the way it works, you have your problem on the left. You say, why is this problem occurring? And you come up with some cause. And then you say, well, why is this cause occurring, right? So again, with the car, why is my car not starting? Well, the battery is dead. Well, why is the battery dead? Well, the alternator is not good. And then you keep going until you get to, maybe the last person that owned this car didn't upkeep it very well or something like that. And then that's really what your root cause is. So you iterate through multiple times like that so you get to your root cause. And then to kind of check yourself again, to making sure that this is like a logical flow of causes from the problem to the root cause, you should be able to go backwards through this process. And so this is kind of like the 5 therefores is the reverse. And so if you started with your root cause saying, well, this car wasn't kept up very well beforehand, therefore the alternator is not good because it never got checked, therefore it's going to, kill my battery, therefore my car's not going to start. And so it should flow both ways, and I think that's a really good way to check to make sure, is my chronicity and my logic working well? Because it should work both ways. And if you get tripped up doing the therefores, then you should really revisit what are your causal factors. Are they actually linked together? Did you come up with something that's a non-causal factor that maybe was diverting you off of the correct course? Okay, so you've thought about different causes. You've checked yourself to make sure that you don't have any non-causal factors. You check to make sure that your logic flows appropriately. And so then the next thing you're going to do is do a fishbone diagram. And so most of you have seen this, but just to go over the components of it. So on the right, you have a box, which is the head of the fish, which is the effect or the problem statements. That's normally, if you come up with a problem statement for your QI project, that's where the problem statement would go. And then going to the left, you have multiple fish bones coming off of the main vein or whatever you want to call it. And each of those bones is a different category that causes related to your problem can occur under. So we come up with different categories so that it's easier to think about different ways that your problem could, or what the causes are for your problem. So, and then you write the causes out on these like diagonals here. And you can have multiple branches off of those main fish bones there. then you go out, and so you can get a pretty detailed fishbone diagram, and that's really where you would be doing like the 5 whys concept. So, you have one category here, you come up with a cause, then you say why, you'd branch again, like that, and then that's where you kind of get a really good in-depth like fishbone diagram. So the traditional way, the fishbone diagram really came out of lean manufacturing, which came out of Toyota. And so the main categories for the fishbone diagram are they're called the 5 M's. So the first one is man, and so it's really relating to how are we utilizing employee skills and knowledge and making sure that we're utilizing those effectively. Methods is the second M, and so these relate to any sort of processes associated with workflows within the manufacturing plant, but this can also be related to healthcare, so any sort of workflows that you have day to day, are the processes associated with those workflows contributing to the problem at hand. Measurement, so how you're measuring things. In a manufacturing setting, you'd have sensors. Are the sensors calibrated? We have similar stuff, in healthcare about if you have timers that aren't calibrated correctly. Maybe you're getting poor turnover times because of that. Sometimes measurement can also be included into environment. So what environmental factors are contributing to your issue? And then materials and then machine are the last two. So materials really raw materials, supplies, any sort of components that you're using to build whatever widget it is. So in healthcare, whatever drugs we're using, whatever supplies that you need in order to carry out your case or deliver patient care. And then machine, which is the tools or equipment that you use to complete the task. So these are the 5 M's this is the original categories that came from the fishbone diagramming. But there's many other types have been invented. So, there's the 4 S's for the service industry. There's the 4 P's in product marketing. And then even Dr. Gilliland, he gave a grand rounds, I think a month ago, and showed some root cause analyses. And these were the 5 categories that he used, which is somewhat similar to the 5 M's that lean manufacturing had, but maybe more related to healthcare. It doesn't really matter which categories you use. You just want to make sure that you have a good breadth and that you're going to be thinking about your problem and the causes of your problem from multiple directions. And then the biggest root cause analysis pitfall that I would say is, we say, okay, let's do an analysis, and then someone's just like, I know what the problem is. It's under man, and it's human error, and we just need to move on. And I think this happened also during Dr. Gilliland's talk, where someone said, well, our providers just need to know how to put in central lines better. And that's actually rarely the cause of what your problem is. Usually there's other systemic things at play. And so really trying to avoid this, going through your root cause analysis in a systematic and then in the full breadth that it's intended to, will really get you to the right spot eventually. So I'm going to do an example with you guys to make this a little bit more interactive. So I have some handouts. So I know Steven's excited about the handouts. I know he brought a pen with. So, the example that we're going to do, so I already came up with what the problem statement is. So I know all the CA1s you guys have done total joint replacements at this point, yeah? Everyone's been in a total joint room at one point or another, done the spinal and blah, blah, blah. So, they all get one?
Can we do a root cause analysis of why work has 2 visitors?
Yeah, that was waste on my part, overproduction. That's one of the lean waste. All right, so this is going to be our problem. And then what I want us to do, we're going to use the 5 M's to come up with causes for this problem. So just use your own experience. So kind of just pour it off into groups. I think we can probably do 4 to a group. So if you four want to be the first group, and you guys, I'll put this back up on the board up here. So if you guys want to do man, you four, and then you four in the back. If you guys want to do methods, and then let's see. Yeah, you guys are methods, and then maybe you three do measurements / environment. So Jess, Lauren, Kevin, and then you guys do materials, and then you three do machines. So just take like 5 to 10 minutes, like come up with some causes. Think about making sure that they can be causal factors or root causes, because both of them can be helpful. Just making sure they're not non-causal factors.
Yeah. Sterile processes. I don't think there's any. We just we're laughing at you.
I know.
Yeah. That's true. Because it's over. Yeah. No, like which one? Like, does it go on this one or this one?
Oh, I guess it was yeah, I mean, you're usually outstanding. If I can get it set up though and then have the tray ready, then that's it. Just pick up that from there and trust it. No, I've asked her to do it.
No, I feel like that's matter. Yeah.
Oh, hey, that's your
Like, I've been looking for like something like it's not super good. Sure.
these are good. I mean, lectures.
I mean, are we supposed to take real?
The only thing we have a problem is that
I don't know.
Yeah, but I think we're all
Yeah. This for sure. But this is like an industrial process. So like
Oh, you're in a different group. Sorry, we'll see you later. Have a good one. Yeah. Professor. I'm the whistleblower right Tweet.
oh, that's true actually.
Yeah, that is one thing about it.
Well, like they can't. They're like the handle. Yeah. Cool. That's a legit.
How in-depth do you want me to do this?
There is, and she's going all in.
Oh, just go. I mean, just take another minute. So.
Like a Harvard level of what
Yeah.
they do in Boston.
I can't do that.
No. VHPS. No.
I
could do that. So I'm not from there. Yeah, right.
So I guess once you're working on your spinal
It's the Harvard of all life.
Well, yeah. All right, guys, let's go ahead and bring it back in. Just go ahead and finish up your last thought. So we'll start with this group here. So you guys did man. So thinking about how utilizing or not utilizing our employees' different skills and credentials may have led to this type of problem. So what'd you guys come up with?
What do we come up with?
Yeah.
We said it's not enough staff. We said sometimes they don't know the right equipment because there's lack of communication with the surgeon. They'll get a bed in the room and it's the wrong bed because they can't get a hold of the surgeon. We didn't know how to frame this nicely, but sometimes the cleaning staff seems lackluster.
Okay.
We said Andrew can help with turnovers.
All right, and then you said not knowing the right equipment. Is that what you said?
Yeah.
Okay. All right, and then you had like one more?
Number of people.
Understaffed. Okay.
We also said like there's a lot of learners setting up a room and getting a room turnover. Like teaching how to do that takes more time.
Okay. Yeah. Having learners around.
That's the root cause.
Okay, good. So I think most of those are pretty good. I think the one that I would, like I was saying before, the cleaning staff, they said it seems lackluster. That would be one, where you're saying like, okay, this is human error that's causing the problem, and that could be it. We could have hired people that are lazy, but usually that's not the case, right? Like, so that would be one where you would want to kind of employ like a 5 whys concept of, well, why do they seem lackluster? Are their incentive structures set up where they're just not incentivized to turn over a room quickly? Kind of things like that to think about drilling down on that a little bit more. But obviously we're doing this quickly. So, okay, what'd you guys come up with for methods?
All of our next steps are far apart, so our drugs are in a different place than our next, like the dropping off our last patient, picking up our next patient, room turnover from cleaning staff, anesthesia techs, whatever, turnover can be slow.
The pre-op nursing process should be its own separate thing.
And I quote from said Nancy, you can just write Nancy.
Okay, well, we're not going to do that. All right, well,
There's no narc bags in PACU, so you have to walk from PACU to
Yeah,
get a narc bag, walk to pre-op, walk back.
yeah.
Oh, yeah.
Yeah, we have to transport patients back by ourselves and
Transporting.
And then also like stuff outside of our room, like the actual room being cleaned, not having enough people for that, or like I don't know if there are processes.
H&P's never being done.
Oh, surgeon.
All right, aspiring a little bit there. Okay, we'll go to the next team. All right, so measurement.
Can I add one to method? Having to now put masks on outside the room.
You don't put masks on?
Like not being able to wear the same mask and having to stop putting masks on.
Oh.
Oh, is that?
That's a J-pop thing though, we're not allowed to change that.
Yeah. Okay. Well, let's put Jake out. So, all right. So for measurement, what did you guys come up with?
So
Measurement's kind of a hard one, but also thinking about like the environment, things like that.
So we kind of tried to come down to like, is it being measured? Like, to say, oh, our turnover time is too long. Like, do we actually have data to back that up?
Mm-hmm.
Or is it just sort of like the bad situations are being like anecdotally noted?
Sure. Yeah.
And then, like, if it is being measured, is it being measured consistently? Like, is it from when the patient actually leaves the room to like actually when the next patient is in?
Mm-hmm.
That sort of thing.
Good. Yeah. Yeah. So all of those would throw off whether or not this is actually a problem or not, even. So.
And then like who's measuring the time? How are they measuring the time?
Mm-hmm. So that one might fall a little bit more in the methods part, like a process with the workflow. But yeah, I could all go in there together. So, all right, materials. What'd you guys come up with?
So ours was basically not having the right supplies with environmental services. the sterile processing having issues, whether it's turning over like specific sets for things, or not having, or just in general, just not having enough sets for whatever, or having holes in sets, or that sort of availability. Things like specifically for total joints, not having like the proper anesthesia supplies, the proper kits for things. And then we put people into materials as well. Just like not having the manpower.
Oh, not having manpower there.
To clean.
Yeah, so that could, you can make an argument for that being maybe in man, that we didn't hire enough people for that, or didn't have enough people on staff that day. Or in materials, I think is another good spot. So, okay, and then machine, what did you guys come up with?
So we know with a lot of overlap with materials, I think.
That happens a lot with these two categories.
Sterile processing issues there. Talks about having an appropriate and or functioning bed.
Yeah, I think that's a good one.
And then just any other like anesthesia machine or computer problems or things along those lines.
Okay. Good. So obviously you want to do this in like 5 minutes, you'd spend more time. But this is, you kind of get a sense of like the different categories, trying to think broadly about different angles to attack the problem and what the causes might be from that. So, okay, perfect. So now we have this, we're going to come back to this. So the summary, we kind of went over this just for the sake of time. I'll just kind of move through it. So the next thing, after you do your root cause analysis, a lot of times you're left with that chart that we just had where you have 20, 25 causes on there. Actually, you did a really good job of asking all your 5 whys and everything. And so now it's like, well, what cause are we going to actually look at to try and impact? So there's multiple ways to go about this, but really, I think Pareto charts are one of the best ways to go about it. So Pareto charts are based on the Pareto principle. And basically, the Pareto principle says that for most events, 20% of the causes lead to 80% of the effects. And so when it comes to QI, what we're really saying is of all the causes we identify, really, there's just a handful of them that are contributing most to the problem. So if we're able to identify just that small handful of causes, then we can get to the effects and actually have a considerable effect with our intervention and with our limited resources. There's actually other examples beyond QI that I found, and maybe I was just hunting for this and found it, but I thought it was kind of interesting that some of this, like the top 20% of earners paid about 80% of the federal taxes in 2018, and in baseball, like 15% of the players are responsible for 85% of the wins. So anyway, so it does show up in like a lot of other places, and the Pareto principle is used. It's not just in like quality or process improvement. It is used like in a lot of industries. So, okay, so then that leads us to what is a Pareto chart. So this is a Pareto chart, and many of you may have seen this before, but it's pretty simple. So the components of it are, it's a histogram of your causes on the bottom. So you see it's a Pareto chart for reasons for late arrivals. And so you have your causes on the x-axis, and then you tally the counts. This is a weird axis. I don't know why there's decimals, but I think someone quickly made this in Excel is probably the problem. But and so you tally, how many people. So maybe there was about 60 people or 58 people who said that traffic was the reason they were late, and then maybe about 40 people that said childcare was the reason they were late. So you make a histogram of that, and then you put it in descending order, which is important. And then you draw this cumulative percentage line. So right here, this point refers to that about 33% of the reported causes of people being late are due to traffic. And then the next one, again, it's cumulative, so about 60% of the causes are traffic or childcare, either of them. And then you keep going down until you get to 100%. A lot of times it looks like this, where the slope's pretty steep initially, and then it flattens out near the top where you get to 100%, because these causes down here don't have a ton of counts to them. And there's 2 vertical axes, the count of whatever cause you're looking at is on the left, and then the percentages on the right. Also use the Pareto chart in the same step, identifying your causes just right after you do your root cause analysis. And so basically what this does is helps you narrow down your causes. And so if we go back to this, then what you do from this point, you draw a line at 80% here. So remember we said about 20% of the causes are going to cause 80% of the effect. So we draw a line at 80% for our effect, and where that intersects our cumulative line here, we then draw a vertical line down, and then all the causes to the left of that, those causes are causing 80% of your problem. And so those are the causes that you really want to focus on as when you're doing your QI project. So in this one, you look at public transport, childcare, and traffic, and you really wouldn't worry about weather anyway, but don't worry about trying to make it so that people don't oversleep or that there's an emergency or whatever. It's really these other causes that you want to look at, because if you're able to solve those, then you're really going to make a large effect on your problem. So that's really how you use the Pareto chart. So it helps you narrow down your causes. Again, it's an easy graphical interpretation. A lot of people have an MBA that you'd be presenting this to have seen this before, and they would know what to do with it. And then it's also kind of a quantitative method. Instead of just saying like, well, my gut tells me that weather's the problem, this actually says, no, like traffic's the issue, and here's the reason why. All right, so there's many ways to create a Pareto chart in terms of getting those counts. So I like the voting method, which is really kind of an expert consensus method. But basically what you do is you come up with all your root causes like we just did, all right? And then what you do is you apply the Pareto principle. So you say, okay, of all these causes, 20% of these are going to be the problem. So if you go back to ours, let's see how many causes we had here. So we had 4, 8, 12, 15, 17. So we came up with 17 causes. So 20% of those is like 3.5. All right, so we'd say like 4 causes are going to be, 3 to 4 causes are what's going to be our problem, or we're going to be contributing most to our problem. And then what you do, so for everyone in the room, I would give all of you 4 votes, okay? And we'll actually do this right now. So here's our causes. So take like a minute. Everyone in here has 4 votes. You can vote on 4 different ones. You can put all 4 of your votes into one if you really think that's the issue. All right, so just take a minute and think about like where your votes would go. All right, so now what we're going to do is I'm just going to read off, and you'll just raise your hand if you're going to put a vote in there, and then maybe put up like a number of fingers that you'd want the vote to be. So for lackluster staff, how many people think that contributes? So 1, 2, 3, 4, 5. Oh, you're doing all 1, 2, 3.
I don't understand the fingers.
Oh, like so you have 4 votes. So if you're like, no, it's the cleaning staff, they're the problem, then you put all your votes into that. Okay. All right. So 1, 2, 3, 4, 5, 6. Okay, 6. All right. So not knowing the right equipment. 2, 3. So not knowing the right equipment to have there.
Which that one's on twice on the material.
Oh, do you put in materials?
Virus.
Well, they may have the wrong supplies. Is that what you guys meant by not having the right equipment? Okay. Okay, so we'll take that out of man. So we'll take that one out. So being understaffed.
Oh, it's the same as I'm looking for.
Yeah, again, in materials. Okay, we'll keep that one in man. So understaffed. So 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. Okay. And then having learners around. 1, all right. Not the problem, apparently. All right, we won't go through all of these in the interest of time, but so having drugs far away. Yeah. All right, is that 1, 3, 4, 5, 6, 7, 8. All right. How about transporting? 4, 6, 7. Okay. All right. Yeah. All right, we'll just do a few more. So how about we'll do having consistent measurement times. 2, 3, 4. Consistent measurement times. Okay. And then we'll do last one, having like a functioning bed. 1. All right. All right, so normally you'd go through all of them, you'd vote. You'd only vote 4 times. So basically, then you'd produce, this didn't port over well to the computer, but I have it up on mine. So I entered all those in for us. So this is our Pareto diagram. And so you can see where at the 80% cutoff, if you're able to look close, you come across and that'd come down about in the middle of the transporting bar. Okay, so we have them in descending order. And so we'd say, okay, being understaffed, having your roads too far away, and then plus minus transporting are going to be our main causes that are contributing the most to our problem, the most effect to our problem. And so then that's what you would then go and focus on, are those 2 to 3 things to try and address this problem moving forward. And then a lot of this other stuff, consistent measurement times, you may forget that for now. The other things that we voted on, you kind of try to leave those out. So, yeah.
So how we decide which ones are most, like, by voting?
So that's one way to do it. Yeah. So that works well if we have, that works well with this group, right? Like, we've all been in the OR, we've all done total joint cases, we've all experienced that maybe there's too long of a turnover time for whatever reason. So we would all be knowledgeable about that. Now, if I got a bunch of project managers in here that worked for the chief quality officer and I did the voting method with them, we would not come up with the correct reasons, right? So we would need to come up with a different process to come to the causes that we want to do. Yeah.
What about all the bias in the room though?
So what are you talking about?
So all of us experience turnovers from our perspective.
Right. Okay. Oh, okay. Yeah. We're all anesthesiologists. Yeah. Exactly. So that's where you bring together a multidisciplinary team is where it's helpful, because you're absolutely right. Us experiencing that everything's there, the drugs are really far away is the reason the turnover times. That's not going to be shared by the environmental staff. They're going to have no clue about that. So so that's why you really want to have a multidisciplinary team doing this. But if you're doing the voting method, you really want people who are on the front lines experiencing the issue, and then you can come together and do the voting method. So another way to do this is that we could calculate, if we had a way to calculate the cost that all of these causes were imposing on the system, then we could just graph the costs, do our cumulative line and do our cutoff at 80% there, and then focus on those. So that's another way to do it, where if you have people who aren't necessarily experiencing this on a day-to-day basis, or just the problem at hand is not amenable to that, then that's a different method to do it. So there's a lot of different methods to do it. I was just bringing up the voting method because we all experience it. But you're absolutely right. Having a room full of just anesthesiologists is not the best team to bring together to solve this problem that affects multiple people. So. Okay, so I had a Pareto chart worksheet, so I'll just hand it out. But we already did the activity. I just wanted to make it quick. Good. So you guys can have that just in case you want to try to use a Pareto chart for your QI project. And then we only have 5 minutes left. So the last thing that I was going to go through was something called a control chart. So I'll just go through it quickly, but I have a handout that you can reference later. So basically, this is what a control chart is. What it is you pick some outcome that you're interested in. So this is from some manufacturing thing. So they're looking at the number of defects in their product. And then you have some sort of time-based scale on the x-axis. So this is presumably sample 1's made before 2, made before 3, before 4. so on and so forth. So some sort of time thing. You have a scatter plot that you plot, and then you draw 3 lines. You draw a central line, which is just your average, your mean. You draw an upper control limit and a lower control limit, and all these they're just 3 standard deviations away from your mean. Okay, so that's what the control chart is. And so what you're able to do with the control chart is you're able to see how your process changes over time with your outcome of interest. And then there's the main utility of it is really to identify non-random variation in your process. Okay, so you're able to see your process going here, and then you want to know, is this just random variation that's going on? Because I can't affect random variation. Or is there non-random variation going on, which is something that I can affect? So that's really what you want to try to identify. So there's a couple different situations. When a process is, quote, out of control, when a process is an unstable trend, and then you can also look at, if you do an intervention on your process, how the variability is changing after your intervention. So you do this at the end, after you're doing PDSA cycles and you're getting data back. So for an out of control process, the main thing, I'll just skip to the chart here. An out of control process is an unstable point, at least one unstable point. And an unstable point is something that falls outside of your control limits. Okay? So that makes sense. If you have a point that falls outside of 3 standard deviations from your mean, something other than just random variation is going on, and it's something you should investigate. So for here, we would look, so November of 2017, we should really see what was going on with our defects, because we had a spike that really can't be attributed to random variation. So that's an out of control process. Then the next one's an unstable trend. And so an unstable trend here is something where you have a run of about 6 to 7 points that are in the same direction. So this one is a run down. So this is actually good. You'd want to look at this and say, what's happening where we're having a decrease in our defects? There's probably a reason for this. It's not random. It could be a run up. That would be concerning. Or you can have a run of 7 points in a row above or below your central line. And that would indicate that there's probably a new process at play, and that you should redraw your control chart and your central line at that point and really investigate what's going on that's causing this new process to happen that you may not be really aware of. So that's it. That's an unstable trend. And then the last one is looking at, if you implement an intervention in your process, so here's your process moving along before that, you implement a change, and you get up here, you really want to redraw your central line and then your control limits so that you can see both how your mean is changing for whatever your outcome of choice is, and then also how your variability is changing before and after the change was implemented. So you can imagine that if I didn't redraw and I just drew central line and control limits for this whole process, my central line would be about here, my control limits would be way out here, and it really just wouldn't tell you anything useful. So this tells you something about what's happened since the change that you've implemented. And this was just an example from the British Medical Journal. They implement some glucose control things. So you can see this was before, this was during their intervention, and then after the intervention was firmly in place, their control chart moving forward from there. So that's just an example in there. So just quick review. We reviewed root cause analysis, how to use a fishbone diagram, the 5 M's from lean manufacturing, but also you can use different categories, using the 5 Y's to drill down on your causes and establish chronicity and make sure your logic is working well. Talked about Pareto charts, the 80-20 Pareto principle, which underlies the Pareto charts, and really the point of the Pareto chart being like, we have a bunch of causes we identified, how do we narrow down to the ones that are going to be the highest yield? And then finally talking about control charts, which is a good way to look at what's going on with your process now. Is something out of control? Is something unstable? Do we have non-random variability? And then what's the effect of a process change on what's the effect of a change on our process, and kind of evaluating that moving forward. So I always ended my presentations with a picture of my dog. So this is Conrad. He's snoozing on the couch. But now I have a kid, so I have to end my presentation with a picture of my kid. And he was a dinosaur for Halloween. I think he's pretty cute. So, oh, it had that. I don't know. Oh God, it's like stuck. I don't know. Sorry guys, it froze, but all right.
Just have it like zoomed in on the very top.
I've got, this is just an overview of the control charts, just in case you want to reference it later. If you want to do that for your QI project, I think they're just super, super helpful tools to use. So, and that's it. So, thanks guys. I am, yeah. This is like the only time.